Very good morning, ladies and gentlemen. Thank you for coming to Ahmedabad. And again, I'm going to discuss the septal defects and septo-optic dysplasia and dilemma. Note, we have we have many good books, and I have few of them which I have taken as a reference for my presentations. You see that we have first one, you have got Malingar, which is written by Malingar. Second one by Ramamurthy. The third one is like the Lauren, and this is the one by Andrea Rigini. So I think you have all the masters for the fetal brain who has written many of the textbooks. They all are here, and thank you very much for being here. There are a few other references which I have quoted for my presentation. I have just enumerated here rather than putting in on every slide. Evolution. There is a constant evolution in humankind and human being, and same thing is with their because today is to 2024, and technology same way evaluates not only the human being, and that the classical example is an ultrasound machine and ultrasound technology, which gives you that evolution has given you much finer imaging inside the fetus and that structure of the fetus, and that's where we all try to look for subtle malformations and try to prognosticate those subtle malformations. How subtle malformations we can evaluate, that is possible only because of the evolution. Previously, it was started from biparietal distance, looking at a skull, as Gustavo said, and now we are looking at a subtle, most smallest defect like that. And one of the smallest and the thinnest defect is a septum pellucidum, and the absence which what we are going to discuss. There's a whole list of malformations. So if you really see that there are few which has got real bad prognosis, there are few who has got a good prognosis. My counseling to the couple that becomes simple. But there is a problem with the group like the which is in the middle one. A borderline ventriculomegaly, ACC, absent septum pellucidum, septo-optic dysplasia. What kind of outcome the fetus after the birth, if they continue the pregnancy, it's going to come? Nobody knows. You are also confused. You make couple more confused, and because of that confusion, they are not in a decisive mode whether to continue or not to continue. So we are going to discuss those kind of malformation defects, what are going to be there, and this is a similar scenario because I don't know whether this is okay or not okay, or probably I feel cannot predict. It is in this group that septo-optic dysplasia lies. Going to embryology, it is this central region where the septum pellucidum, optic chiasma, and hypophysis, which are going to be developed. And for that, you need to understand the laminara reunions and laminara terminalis. And I will skip that part slide, but this is one area where, in case of when laminara reunions gets thicker, little bit, it's a solid component, and that's from solid component. There are some small little vesicles which develops, and then eventually only membrane remains, and that is how septum pellucidum develops. Initially it was a solid part, and then little gradually it converts into the cavum. Cavum means a full fluid filled space, and that is what we call it as a cavum septum pellucidum. And this cavum septum pellucidum is a kind of, again, a part of diencephalon. So you have got at this area, from this is the area, the entire diencephalon development starts, optic chiasma and septum pellucidum. It comes down in this manner. So a lumen of diencephalon, and this region, if you see, this is one image, but let me put it on simple graphics. Diencephalon, you have got the Rothke spout, and then it is going to create a third ventricle, depends up, and then the Rothke spout, which gets practically touching to the third ventricle, and from the same you will have an optic chiasma, pituitary, neohypophysis, adenohypophysis. That's how the embryology develops. But when you have got an insult at this point where I have put it a red mark there, then what happens? The lower portion usually is not going to be developed, and that where you will have a kind of possible problems of the optic chiasma, fused mammillary bodies. You may have absent septum pellucidum, corpus callosal malformations, hypopituitarism, and maybe ectopic pituitary, is because it has got no fixed location, and that's the reason. Of course, we are. If I remove the brain, it is what I'm interested practically in this region, and where if we are, what we are going to discuss is this region now, and that is where you have got an optic tract. This is the pituitary or hypophysis, and then this is where you will have a mammillary bodies and the corpus callosum, and this is the coral plexus of telencephalon, or what we call as a tila choroidi, and that's what we are going to discuss, that region. If you convert it to the base of the brain, the same region is actually like this. You have got this one optic nerve, another optic nerve. This is the chiasm, the optic tract, another optic tract. But look at the hypophysis or pituitary, which is coming at the base. And if you cut into this section, you have got a septum pellucidum, which we have already discussed that part. And the boundary, if you look at the superiorly, it's an inferior surface of the corpus callosum, which is going to found the upper boundary, and row inferiorly, it is going to be the genu of the corpus callosum. Posterior inferiorly, again, is going to be the corpus callosum and the columns of the fornix. That's how is going to be the base. But you can see that this is the very clear septum which is going to be there. It's a medial wall of lateral ventricle. We call it as a septum pellucidum. So brain, because that is one of the important landmark. If you see all sections which you evaluate, everything which should have cavum septum pellucidum, that means the septum pellucidi has got huge importance in every section. If it is not cavum septum pellucidum seen, your image is probably, we consider as an invalid, right? So that's the importance of septum pellucidum. And so if you done, the moment you convert in a coronal plane, this is exactly the ultrasound, and this is the autopsy specimen. That's what you are going to look for this. So I would put it across that I have one case of absent septum pellucidum as an autopsy. I want to show that, okay, what kind of anomalies you are looking for. Okay, septum pellucidum present, septum pellucidum absent. Fornices are to separate here, which is fused here. Look at the shape of the anterior horn here on the bending on like this. Practically, it's just like a straight one. These are the three important things which are important as far as coronal sections are concerned. And other things are going to be, you can always look at the base of the brain for an optic nerve, optic tract, and chiasma. So this is what exactly I'm trying to put it across, that because the optic chiasma not developing, neurohypophysis can be located anywhere, what we call a ectopic pituitary. So this is what we will be discussing. All in all sections of coronal sections looking for the septum pellucidal defect, you can have that's a region what we are going to discuss. Now, absent cavum septum pellucidum and septoptic dysplasia. What is the relationship? How to prognosticate? If you read the books or references, it's considered as a three things, as a triad of combination. You may have a brain or optic anomalies, then you may have a genetic association and a possible pituitary anomalies. And these are the things which we are looking at is ASP, septal remnants, fused fornicel columns, ventriculomegaly, and a bilateral hypoplastic optic nerve. That's what we try to evaluate. That's what which is being written associated with ASP. So we try to look for those structures. And what we try to look on ultrasound, the best evaluation is a coronal image. And the moment I look at a coronal image, FOX is good, suddenly the membrane is broken and you have got a fused anterior horns. If you take an MRI, again you will have the same kind of combination or same kind of fuse. You don't see the septum pellucidi. All sections, fused images, autopsies. That's what you can correlate that. Okay, this is what you are going to look into the details. It's a combination of ultrasound. You can have TUI or a volume imaging. Volume image will give you precise information, and addition of MRI may give you lot of information as an additional thing. This is a slide which was shown yesterday also, looking at the absent septum pellucidum, a three-dimensional structure, but the best thing I always prefer to walk in. The moment you walk in, all sorts of possible associated malformation I will try to look at. These extensions are probably better appreciated on your volume. The fornicel fusion, single fornices, which also will have a better appreciation on a volume. But absent septum pellucidum can be because of the severe hydrocephalus, which creates more intracranial pressure, and you may have rupture. But the rupture will have a remnants of or a floating septum, which can be appreciated. So your cause, as yesterday Nitin and Chandar discussed about the severe ventriculomegaly, where you may find this kind of absent septum pellucidum. So Is it isolated ASP or associated with septo-optic dysplasia? There are three, as I discussed, three things to look for, and try to attempt visualization of optic chiasma on scan or MRI. Is it present, absent? Maternal serum estradiol level, it is indirectly indicative of how fetal pituitary is functioning, and fetal blood for growth hormone and ACTH and prolactin. This is, but it is an invasive testing. So we usually do not promote or make that you should be looking for that. This is to be done if at all you don't find a pituitary and is a pituitary fossa even on MRI, then you may opt for this investigation as confirmatory investigation. Although the presence of optic chiasma does not confirm the normality of optic nerve functioning, but the absence of optic chiasma by ultrasound and MRI may confirm a possible compromised outcome. So as I told you, there is a classic triad: optic nerve atrophy, hypothalamo-pituitary dysfunction, and absence of septum pellucidum is a classic triad. We call it as septo-optic dysplasia, and usually there are three different varieties, and it has got multi-etiological origin, including disruptions of anterior cerebral artery, viral infections, and the genetic kind of association. So optic chiasma, when we are looking for, there are many things. If you are evaluating at a mid-sagittal section, then this is the place where you should be looking for. If I'm evaluating the base by volume, I should be looking for this kind of image. If I'm looking at a coronal view, these are the places where I will be looking at an optic chiasma. Again, just zooming that portion, that the hypophysis is just behind that. But one of the most important section is this. I have removed the brain while doing autopsy. This is the base of the skull. And on the base of the skull, at this region, you are usually looking at a middle cerebral artery. And if you can see this small little hole, that is where the optic nerve enters into the orbit. So the course of the optic nerve is so short that it is always going to be challenging to evaluate the optic nerve itself. What you may see is usually an optic tract and optic chiasma, which will be possibly visible. It's not the optic nerve which you try to evaluate. Yes, possible in MRI you may go for, and you may possibly detect. So as I told you, that usually the optic nerve it is going to be around middle cerebral artery, and middle cerebral artery, is it easy to evaluate or difficult? Easy. That means you go to the base of the brain, simple, and then click on the color. You have got a middle cerebral artery, and in this middle cerebral artery, this middle portion, this portion is simple. It's an optic chiasma. So because everyone is looking at a middle cerebral artery, but we have never tried to look at an optic chiasma as an optic chiasma. Now your vision will change from only middle cerebral artery. Now you will start thinking about the optic chiasma. Okay, I can see something which is not picking up the color. Because it is not picking up the color, this is tend to be optic chiasma. And then if you go back, you may find some of the optic tract. So this is on the color to identify that. But even without color, this is the septum pellucidum. You go down back, and then you can see, okay, yes, there is an optic chiasma which you are dealing with. This is an optic chiasma. Switch on the color, confirm it, and you can do it. In the coronal sections, you can have the again vascular anatomy, which can give you idea about what the region you are looking for. But the easiest, because again I am a fan of volume imaging, I've put in all three sections of the brain, and there is one easy way how you can track the complete optic region along with the pituitary. I will show you. The entire game, if you can probably appreciate, there is going to be a one reference dot, and the game is like playing with the reference dot. Okay, so I'm here. I've started moving the reference dot. You can see this line, orange line, which is coming down. So my reference dot is here. So I'm going to cut. You can see the anterior horn, which is not functioning. I mean, it's ASP, absent septum pellucidum. And from here, if you can, I don't think you are able to see that reference dot. The moment I evaluate the reference dot at the base, when I reach at the base of where the reference dot is kept, this is an optic nerve region. The moment I put my reference dot at that point, I can see the optic nerve roots and optic chiasma, and that's the easiest way. Grab a volume. You have already diagnosed septum pellucidal defect. You put your reference dot coming from the septum pellucidum, go down, track to the optic nerve origin, and in orthogonal planes, you will pick up both the sections of the optic chiasma. That's what you will be looking at. Now you have seen. You have seen means you are going to measure it. Now, which is where we are entering into a difficult zone, inconclusive zone we are entering. Now there are many charts. As I told you that this is one optic chiasma, that okay, it has to be this millimeter, that millimeter, and there is going to be algorithm. Now algorithm nobody remembers. It's difficult to remember this either algorithm or thing. One simple rule: if the width of optic chiasma is less than 1/4 of the gestational age, it is below fifth centile. This is as simple as that. Okay, so one simple rule: 1/4 of the GA. If you are evaluating 24 week, if it is below 6 mm, that means you are dealing with small optic chiasma. Look it carefully, and I have given you an example. That's how you calculate, because 0.078 millimeter does not make any sense. It's a mathematical algorithm. On ultrasound, 0.078 millimeter does not make any sense. So it is practically 1/4 of the thing. You go ahead and evaluate, and that makes life easier. I'm going to show the role of power of ultrasound. There is on one side you have got ultrasound image, on one side you have got practically the MRI image. Whatever you are looking at on MRI, you are practically looking at a flat base of the brain. You have got absent septum pellucidum, exactly what you try to evaluate, and we have the same kind of ultrasound images, and you can usually take it. The 3D is going to be phenomenally key, not for the diagnosis, but looking for other structures. Diagnosis is done on a 2D, one coronal 2D, your diagnosis is done, you are dealing with absent septum pellucidum. But looking for septoptic dysplasia, it will the 3D, which may help you in identifying the things. These are the narrow CSP, again, one of these structures where you should be looking for, and that's where it may give you some kind of additional information. There are a few phonacial columns that also adds on, but there are different gestation where MRI helps, and these are the courtesy Professor Andrea Rigini. He has given me these MRI images because we are not dealing with MRI in every patient there. So I got it from Professor Andrea Rigini. Thank you very much for supporting. Here, thank you. So you have got all at a different gestation. You may have a different cortical development, but the size may be different, and that's how MRI. You may have different elements going all together. So now confusion prevails for absent septum pellucidum and SOD because of less than 1/3 of the case present with the 3 features of SOD triad. So your association may not be always. You may have 1, 2, or 3. Only absent septum pellucidum converted at the end or after the birth. It may have ocular problems. So there is no fixed route, or there is no fixed role or a rule which these things are going to produce. The severity of age onset may also vary, and the clinical heterogeneity, it's also one of the problem which is also creating one of the problem. So it is again one of the study by Gustavo. He said that our results suggest that although we cannot distinguish between the cases of absolute certainty, the isolated absent septum pellucidum is usually associated with favorable outcome. So again, it has got favorable outcome in maybe 60%, but I'm interested in identifying those 30%. If everything is good, couple is not going to come back to you, oh, doctor, you have done good and our kid is fine. They'll come back only if they are in rest of the 30% or 40%. So my interest is to look for not good outcome cases. My primary interest is to look for those bad cases, and that's where my counsel, because in India, it may be a little bit different practice than what you are doing in the Western world. They'll come, why this was not diagnosed. They expect you to diagnose every little malformation at 2 months of the pregnancy. Right, so that's their expectations. So we may not be able to cope up with that. So eventually, as I told you, that there is a triad, and these are the things which you will be looking for. In genetic tests is always going to be microarray, whole exome sequencing, and torch PCR. For HP-axis, it's an histriol level, and you should be looking at it. Once you find absent septum pellucidum, let us go to algorithm how to do that. The communication at the level of the foremost portion of lateral ventricle, is it yes? then it is not there, then you are dealing with holopros and Kifeli, lobar, semilobar, or alobar type. If you can see that, okay, it is there, then the separation of anterior horn of lateral ventricle, is it there? Then look for the change of the cortex, or cleavage of the cortex or basal ganglia. If it is non-cleavage, you are talking about the midline interhemispheric variety of holoprosencephaly. If it is normal cleavage, look for the septal remnants. They are there, then you may be looking for hydrocephalus. If there are no septal remnant, look for the cortical malformations. If there are no cortical malformations, if there are yes, then it is schizencephaly, and no, then there is a possibility of absent septum pellucidum which is isolated. Then you try to look for the optic chiasma and whatnot. So your journey for looking for optic chiasma starts at this point. So ultrasound, MRI, or both. So symptomatologically, it is same with MRI and ultrasound. But there are a few advantages. MRI has got a better look at an olfactory sulci bulbs by MR. Gray matter heterotopia, which is practically difficult by ultrasound unless you are very experienced sonographer or a consultant. Ectopic neurohypophysis can be seen better on MR. Optic nerve, optic chiasm, and optic tract sheath may be better visualized where, because on ultrasound you are never going to be distinguished between the sheath and the optic nerve. So there is a difference, and that can be better perceived by MRI. There are few advantages of ultrasound. It is always better. I believe ultrasound is better before 26 week to look for, because of the less ossification of the bone, it's a dynamic examination. You want to change it, you can change it anytime. You want one more examination, you can ask that lady to redo the examination, but which may not be that as good as the MRI on that. So once you have got isolated cases of ASP or ultrasound, you are adding the genetic testing, because at least these many genes you need to ask, or because enophthalmia and association with the various genes which are going to be different with the different malformations. So other environment factor, there is a whole list of it. One infection, maternal insulin dependent diabetes. So this is the thing. That means the more are the causes, more are my investigation. The umbrella becomes bigger. So that's a difference, because there is a whole load of investigation you should be looking at. And again, this is the same Gustavo paper. If you look at the table 5, he said that the neurosonography includes measurement and whatnot, and then the measurement of estradiol level, MRI, chromosomal microarray on whole exome sequencing. That is all what you need to do that. Absent septum pellucidum does not only stay there. I think we have discussed this case, so I think I will skip that case. But the abnormal shape of the septum pellucidum or anterior complex, please always think about associated other malformations also. Again, I'll try to save 1-2 minutes extra also. So some of the take-home messages are like this. You have taken a photograph, but it is blurred. First, ASP is easy to diagnose, easy to take photograph, but then difficulty starts. The SOD is usually difficult to diagnose antenatally for a precision with the diagnosis. More difficult is to predict the outcome. And then it comes the fetal MRI, which may add the information of ultrasound in the later gestation if done with the thinnest slice. Torch, PCR, microarray, and whole exome sequencing is a must. So when you see absent septum pellucidum, please go ahead, look for optic chiasma, look for measure it. If it is small, you may have some kind of problems. Do the invasive testing. Invasive testing is must. And at the end, it ends up if you have got some malformation, counseling becomes easier. If everything is normal, isolated, then with a word of caution, counsel them that usually these cases can have a better prognosis. No, never ever use a word good prognosis. Use a word, it's a language of a lawyer, right? You have to write like a language of lawyer, you have to counsel like a language of lawyer. You may have a better prognosis. So the moment you talk in that sense, it is going to be always better in counseling. Thank you. Thank you very much for patient hearing.
Thank you, sir, for this amazing talk. Next, we have Dr. Lauren Guiba for his talk on short or thick dysgenetic corpus callosum.
So thank you, Prashant, for your kind invitation and the quality of the hospitality in India. It's incredible. I'm very glad to be with you. I'm glad also to present this lecture about the genesis of the corpus callosum. And we'll go from routine ultrasound to neuroimaging and to prenatal counseling. And I include in this presentation recent genetic data, because we cannot speak about corpus callosum dysgenesis without speaking about genetic. So some brief reminder, you know, when we speak about corpus callosum, we have to have a good imaging mid-sagittal image here at 24 weeks. And for anatomy, this is the rostrum, this is the genu, the body, and the splenium. Oh. There is some issue with and regarding the embryology, corpus callosum is the last commissure to form around 11 weeks. And first, formation of the genu, after body, then splenium, and at the end, the rostrum, which is the last part formed. If we speak about callosum anomalies, there is a very confusing terminology, and we yesterday emphasized this point. Complete agenesis is very simple. There is no corpus callosum. If we speak about hypogenesis of the corpus callosum, it's a partial absence of the corpus callosum, also partial callosum agenesis. When we speak about short corpus callosum, it refers to decreased corpus callosum length. And as Ro yesterday say, we should be careful using only calipers and normograms. And in that case, the callosal anomalies should be normal. But it's very difficult to differentiate from partial agenesis in routine practice for subtle partial corpus callosum agenesis. And in that case, it's interesting to have a precise imaging. And on my experience, ultrasound is better than MR due to better spatial resolution. When we speak about corpus callosum dysgenesis, it refers to too thick or too thin corpus callosum, often associated with short corpus callosum or partial callosum agenesis. And as you say, it's very confusing. And if we want to have some images, this is very simple. It's complete callosal agenesis. In that case, you see a very small butt of corpus callosum, and it's major form of partial agenesis. In that case, it's a minor form because you see almost all the corpus callosum is short but incomplete. You don't see the interior part, and in that case, it's complete but it's too thin, and it was confirmed after birth, and it was a metabolic disease, PDH deficiency. If you look at this one, it's simple. It's too thick and too short, so it's a real dysgenesis. But all these diagnoses are based on strict mid-sagittal plane. And as you know, basic routine sonographic exam of the fetal brain is performed only on axial plane. And in that case, the main items to assess the integrity of the midline is the cavum septum pellucidum. And as question say, it's very easy to identify. It should be visualized, as Dario said yesterday, between 18 and 37 weeks. And it's altered in many pathologies involving the midline, as question told us. But in our casuistic, we saw some false images of CSP associated with complete agenesis of the corpus callosum. This is patients referred for isolated ventriculomegaly. And in the report, it was said that the CSP was normal. But what you are looking at, this square box, it's not the CSP. It's just the ascension of the third ventricle. And it's a false image of the CSP compared to the normal cavum septum pellucidum here. In that case, normal cavum and normal corpus callosum. And in the other case, complete genesis of the corpus callosum. And this case and similar case led us to introduce 10 years ago the term anterior complex in this letter of the editor. And now this term of anterior complex is widely used because all people say about anterior complex. But in the anterior complex, it integrates the CSP, the frontal horns, the genu of the corpus callosum, and also the interimic fissure. Is it worthwhile to look at this interimic fissure? Yes, it is. And we have published a paper about distortion of the anterior part of the interimic fissure and this significance and the implication of prenatal diagnosis. Now we know that distortions is very important to diagnose Aicardi syndromes and tubulonopathies. This is something which is very important, and we were not aware of this some years ago. If you look at the anterior complex, you look also at the CSP, and you have to look at the shape of the CSP. As it was told yesterday, the epi diameter should be greater than the transverse diameter. If it's the inverse, in that case, our friends Catherine Guirel and Rabi have published a paper, a similar paper, about the fact that what is inverse, you should think about partial corpus callosum genesis, and in fact, it should be corpus callosum dysgenesis. This is a case here when you see clearly that the ratio is inverse. And if you look at the sagittal view, you see too thin, too short. It's a dysgenesis of the corpus callosum, and you see that there is parallelism of the lateral ventricles. All this was confirmed on MR. This patient is doing well at 7 years of age. And as you see, there is parallelism, and also there is dysmorphism of the frontal horn and a mild colpocephaly. In fact, the more subtle the dysgenesis, the more subtle are these indirect findings. But nowadays, in France, most practitioners do their best to get a mid-sagittal view to explore directly the corpus callosum. But this led us to an increased request of prenatal counseling for short corpus callosum on mid-sagittal view. And it increased also the anxiety of the couple. In some cases, it's very simple. It's just a matter of a method. It's a off mid-sagittal plane leading to a false positive, as in that case, it was measured like that. And if you do a good measurement, it's a complete corpus callosum. In some cases, the corpus callosum is length, but the corpus callosum is short, but the frontal occipital diameter is also reduced. How we should do that? In fact, you should refer to this article and to the ratio between the internal cranial occipital frontal dimension and the length of the corpus callosum without referring to any normograms. This is, in fact, very useful in practice. But some true corpus callosum are confidently associated with a good postnatal cognitive outcome. This is a case where you can say short, but the prognosis is good. Why? You may wait some weeks, and if you wait, you see that now you see clearly an echogenic band just above the corpus callosum. It was, in fact, tricky to find this at 23. This is, in fact, a corpus callosum lipoma. And it's tricky with MR because if you, it's the same patient. After birth, you see it's hyperintense on T1. But the nature of the fat is not the same before and after birth. And you don't see any hyperintensity on T1, but hypointensity in T2, it was due to chemical shift. So this is a limitation and pitfall in the prenatal diagnosis of this pericallosal curvilinear lipoma. But it's very important to diagnose this lipoma when we are dealing with a short corpus callosum because it's associated with overall excellent postnatal prognosis. This was also confirmed in this paper from the team of Gustavo, and they say isolated pericallosal lipoma is associated with a favorable neurologic outcome. This is two types of lipoma, the curvilinear type, most often isolated, and the tubular nodal type, huge one, entirely, most frequently syndromic. Here you have a case of lipoma, and there is also anomalies. You see that with bilateral cutaneous cleft lips, bifid nose, and some appendages. And in that case, it was a case of Pie syndrome, and we report the first case of Pie syndrome. And what is interesting with Pie, the cognitive outcome of Pie is good also. So pericallosal lipoma, in fact, give rise to degenesis of the corpus callosum related to obstacle on the midline, which prevents neurons to cross at the commercial level. So it's a degenesis, a mechanical callosal degenesis. There is one etiology, lipoma, but also interhemispheric cyst. In that case, it's for lipoma, it's overlooked, but for interhemispheric, it can hide the callosal degenesis if the cysts are very voluminous and can mimic tumoral lesions. As in this case, you see a very huge cyst in the midline, and if you look carefully here, there is a part of the corpus callosum which is present. The other part is missing because of the cyst. And you can see also with MR, but you see that the definition, the spatial resolution is better with ultrasound than in MR in that case. This type of huge cyst can be associated with polymicrogyria, but you should be aware that in some cases you may have some aberrant sulci like this one, but this is not polymicrogyria. The cortex is absolutely normal here. It's a mechanical, in fact, tract on the surface of the cortex, which lead to a mechanical deformation of the cortex without underlying cortical dysplasia. So in that case, the prognosis is not related to this cortical malformation, which is only a macroscopic malformation without any histological deformities. So corpus callosum degenesis should lead also to look for other CNS and extra CNS features. And it's important for prenatal counseling. And in a few cases, this may lead to identify precise syndromic entity. I will show 3 cases like that. The first one, so I will do like Dr. Porti. In that case, there is complete agenesis with cyst. It can be complete. It can be degenesis in this syndrome. There is distortion of the interhemispheric fissure, and there is subependable heterotopia. And which is important, it's a femur. So in that case, you should look at other things. Here, there is segmental anomalies of the Behr sepal, very focal, and this is suggestive of Aicardi syndrome. And you will do the diagnosis only with imaging because exome is not useful because the gene is not yet identified. And all this was confirmed after birth. You see here the cyst. There is a cyst here also. There is epilepsy after birth, and of ophthalmological examination, there is lacuna. So it is a confirmation of the diagnosis. You know it's triad. You have the disease of the corpus callosum, the chorioretinal lacuna, and the epilepsy. But in the prenatal diagnosis, we found a pattern which is very suggestive of the diagnosis, and we published this pattern with most of you. The degenesis of the corpus callosum is always present, can be shown, as in this example, and it associated with distortion of the interhemispheric fissure and the cyst in all cases. There is also other anomalies. mainly neuronal heterotopia, but also focal polymicrogyria in a female fetus in more than 90% of cases, but also other extra-CNS anomalies, ophthalmological anomalies, and focal vertebral segmentation, as I show you. This is a second case. In that case, you see there is a corpus callosum. It looks weird, short. The thickness is abnormal, and we did an MR. Is there something wrong on the MR? There is something wrong, and we miss the features. Oh, yes, you see, you get it. Asymmetry of the. Yes, the frontal horn, the dysmorphism of the frontal horn, but you have not to look at the brain. Look at the mandibula. You are cornal strict. It's asymmetry. And one thing is missing. There is no hair and no middle hair in that case. And it was a Goldner syndrome. And we missed, you have this diagnosis, Dr. Murthy. And in this publication, we see that CNS anomalies is also associated, and especially corpus callosum anomalies. The third case was a little bit tricky. We follow this patient for a triventricular ventriculomegaly suggestive of incomplete atrial stenosis, and we did an MR at 34 weeks of gestation. This is the ultrasound, and the corpus callosum at 34 was 33. It was, in fact, too short. Complete or not, difficult to say. We did an MR. In fact, the dygenesis was present, and in that case, the dilatation was only moderate. But if you look carefully at the thumb, there is adduct thumb, and it was confirmed that it was a LNCAM mutation, and it was confirmed after pathologic examination and with the exome sequencing. But all is not genetic. This is a very healthy, wealthy woman, very nice woman. And at 28, this patient was referred for corpus callosum dygenesis. It's too short. We did an MR, too short for sure. And this case turned to be a fetal alcohol syndrome. And fetal alcohol syndromes, the incidence of dygenesis of the corpus callosum is high, almost more than 5% of the cases. How can we improve this dygenesis? With imaging, for sure, but we have to go to genetics. Some years ago, what we did, we looked for chromosomal anomalies, for MR, for consanguinity, for family history. It was isolated. We say the prognosis should be good, with the outcome good in around 70 and 80%. If there is anomalies, it was most likely a poor outcome. So in case of isolated corpus dygenesis, parental decision to continue or terminate was based on statistics, a sort of Russian roulette. Nowadays, we have a better understanding of the genetic etiologies, and we have also the fact that we can do an exome. And most of the time, poor prognosis are related to underlying syndromic entities. It can be related to chromosome in 10 to 15%, but it up to half the cases, it's a genes mutation. And in that case, it was not identified before exome sequencing. So to help parental decision, we conducting a multicentric study in France and to test known genes of corpus callosum genesis and genes for anterior deficiency using trio whole exome sequencing in fetuses presenting with all types of callosal anomalies. Most of them are syndromes, dominant syndromes. Some of them are only, in most of the case, isolated dygenesis, like Coffey series syndrome, with a very poor prognosis. On the other hand, some of them are of good prognosis, like a DCC syndrome with the Maillard movement, and Gustavo told yesterday about this Maillard movement. And this is the result. All this was conducted by Dr. Héron in France, which is in charge of the genetic workup for callosal anomalies. You see, there is most of them were isolated. There is some associated, and what we call mechanic, it was lipoma or cyst. There is complete genesis in almost 1/3, short corpus callosum in 1/3, and the other third were dysgenesis or partial dysgenesis. We get the result in less than 3 weeks, and there is additional information in almost a quarter of the cases. With a large genetic heterogeneity, we have plenty of genes that give rise to this kind of dysgenesis, but one gene is predominant, is DCC. And there is also RNB, which is responsible for Coffin-Siris syndrome. Most of them are de novo dominant genes that may mean that consanguinity is not, in fact, a very important thing when you are dealing with dysgenesis. There is some isolated cases and some associated dysgenesis. If you look to the isolated, you see that in up to 20% of the case, you have additional information provided by sequencing. And when it's informative, in 20% of the case, it was DCC. And DCC is a gene with a good prognosis. So it's very helpful for the patients as a couple to have now this kind of new genetic tools. And if you are dealing with mechanical dysgenesis, no variant in that cases. But some seems to be simple. And in fact, it's not as simple. All this is based on database. And this was the case. What this was difficult, it was isolated. You see there is a dysgenesis. And in fact, on prenatal sequencing, we found a nonsense homozygous variance on a gene located on X chromosome in a girl. And this variance is involved in cognitive deficiency on database, but very few cases report, and none of them have dysgenesis of corpus callosum. What should we do with this information? And this, the weakness of the prognosis based on database, is why we have to publish a lot to increase, in fact, this database and improving, in fact, the counseling. If we do corpus callosum dysgenesis NMR for the fetus, we should do also parental cerebral MR, because in almost 10% of case, we have more information, and we found some anomalies on the corpus callosum on the parents. Which type of corpus callosum anomalies you have, and is there some correlation between imaging and genotypes? And this is a multi-centric retrospective study by the team of Catherine Guérel and Delphine Héron. And you see that we have complete and partial genesis, short corpus callosum agenesis, dysgenesis, and mechanical dysgenesis. In that case, it was isolated or not, and the variants were more frequent in dysgenesis and not isolated anomalies for sure. And in the case where it was a short, with a normal corpus callosum, no variants, nor also in mechanical dysgenesis. There is no correlation between the phenotype and genotype, except for fetuses with tubulonopathy and mTOR pathologic variant. And for mTOR pathologic variants, it's for sure a very typical phenotype, because we go now to finish with on six corpus callosum, and we know that 6 corpus callosum can be a transit finding, and Gustavo told us and learned us a long time ago that this is in fact something that you can find in your routine practice, and this is a case that we published with Catherine in her book on the fetuses and neonate. And you see that in the second trimester, the corpus callosum seems to be too thick, but at the end, it's normal because of axonal pruning. And Gustavo published also a paper on thick corpus callosum, and this is something which should be of concern. In fact, it should be concerned when it's associated with other anomalies, especially macrocephaly, ventriculomegaly, posterior fossa agenesis, or abnormal sulcation. And this is a case that I show you. And if we look at this case carefully, I show you this case yesterday when we speak about ventriculomegaly. In that case, there is macrocephaly, and it was a megalencephaly due to conjunctival acathetria variants. And we published this paper about this disorder leading to overgrowth on the brain, and not only on the brain. And in that case, you may have, when you have megalencephaly, in almost all cases, a thick corpus callosum. So to conclude on dysgenesis of the corpus callosum, there is multiple phenotype, and the terminology is very confusing. Complete agenesis, short, thin, thick. It can be associated with cyst and lipoma. It's easier when there is mechanical dysgenesis. It's important to perform dedicated fetal neuroimaging to improve characterization. You may remind about the subtle pericallosal lipoma with the increased ecogenicy during the pregnancy. We have to look for associated anomalies that you know that, and it should be a multidisciplinary approach to improve counseling. And nowadays, I think that genetics should be, in fact, on the top of the specialty. We improve in the future the counseling of this dysgenesis, and because the variants are encountered in almost half of the etiologies of this dysgenesis. And to finish, we need to improve the database, and it's your role to publish your cases to improve the database. Thank you very much for your attention.
Thank you, sir. Any questions, anybody?
One of the difficulties we face when we offer exome sequencing is when we detect a variant of uncertain significance. When we detect the exome sequencing reports back a variant of uncertain significance rather than a pathogenic or a likely pathogenic, in which case, what do you exactly tell the parents?
In fact, it's not my role to do the report. It's a genetician who do this report. In fact, you are right. It's important to do this test, but it's important also to have the knowledge to speak to the parents. Some of genes, for sure, they are pathological. Some of genes, there are only variants of insignificant signification. So in that case, there is genetic consultation. And during this genetic consultation, we will do the report. It can be very simple when it's coffin series. It can be tricky. And I show you a case where it was tricky because there is no real information, relevant information to give to the parents. So parents are aware that if they do prenatal exam sequencing, they may have their answer, but they may have not informative answer. Yes, but the more we go, the more we have good database, and it's the same thing. We go from the exome to genome, and we think that genome will enhance your knowledges and will improve the prenatal counseling. The fact is that with genome right now, we don't have many information about the non-coding part of the genome. It's why we have to wait to have a real improvement going from exome to genome.
Thank you.
In France, we don't with Delphine Héron, and we do this work with Catherine Guerrel also. We don't differentiate between agenesis, partial agenesis, thin corpus callosum, short corpus callosum. In all cases, we do exome sequencing. If parents are in fact aware that this information may interfere with the decision of doing termination or continue. If parents say, in all cases, we will do termination of pregnancy, will not do a prenatal exome sequencing, it's only if the answer may interfere with the parental decision.
Hello. Thank you, sir. Next, we have Dr. Christian Mitter, neuroradiologist from the Medical University of Vienna, Austria, with more than 10 years experience in fetal MRI and fetal cytograph.
Oh, thank you very much for the introduction, and I want to thank Prashant a lot for the invitation here to this amazing congress in this wonderful location. Topic of this talk will be the apparently isolated agenesis of the corpus callosum and the focus, now I have the laser pointer. The focus of this talk is on the word apparently. So the corpus callosum, as we all know on fetal MRI, can be seen from about week 15 to 16, here in early week 16 as a thickening of the lamina reunions. And later it can be visualized with in utero tractography in its three-dimensional shape. For example, here you see the genu of the corpus callosum and here the splenium in blue. Tractography is especially helpful in cases of partial agenesis of the corpus callosum, in abnormal thick or thin corpus callosum, and in destructive brain lesion. Now, in callosal agenesis, obviously there is an absence of the corpus callosum, but as has been demonstrated in 1901 already by the Austrian neuroanatomist and psychiatrist Moritz Probst, the brains of patients with callosal agenesis have an abnormal, peculiar anterior-posterior oriented fiber bundle, which causes medial to the lateral ventricle, and which Probst called the Balkan Längsbündel. And already he noticed that this fiber bundle actually is composed of misdirected commissural fibers that don't cross the midline, but instead run along the lateral ventricle bundles. And so the name corpus callosum agenesis is actually a misnomer. It's not an agenesis of commissural fibers. It's a heterotopic projection of fibers. And those bundles since then are honorary in honor of Probst, called so-called Probst bundles. Probst bundles can be visualized in utero with fetal TI, as you can see here in a 28 gestational week called fetal brain, as these blue fiber structures. And this is the same case a few months later, postnatally, where findings are confirmed. Here, see here you see a movie of the tractography finding in a 29 gestation week called brain. Here again in blue, the Probst bundles as this abnormal anterior posterior directed fiber bundles medial to the lateral ventricle. And in green, you have in reference the internal capsule fibers. This is how it looks on histology. See here in utero tractography at 20 gestational weeks, and this is the same brain a little bit later in histology. This is how a Probst bundle looks like in perpendicular section. You see it's a thick fiber bundle, anterior to posterior direction with lots of fibers containing it. And this structure here underneath it is the the fornix, which is connected underneath to the Probst bundle, just like it is in a normal brain under the corpus callosum. Now, tracheography of Probst bundles is a proof of agenesis. It can help in cases of partial callosal agenesis, but like in these cases here, these orange fiber bundles are remnants of corpus callosum that manage to cross the midline. But the problem is that tracheography findings as yet don't offer us a clue how the functional prognosis of the fetus will. So it won't help you to make the prognosis if this fetus will have a good outcome or better outcome, like Darshan would put it, or a poor outcome. The reason for this is callosal agenesis is a condition and not a disease. So in fact, there are more than 200 different diseases that are associated with callosal agenesis. So callosal agenesis is sort of tip of the iceberg of an underlying brain disorder. And for prognosis, usually the distinction is made between isolated callosal agenesis and associated callosal agenesis. And from postnatal outcome studies, we know that actually most of the cases of isolated callosal agenesis have not that bad of an outcome, whereas most of the associated callosal agenesis have a rather poor outcome. Problem is that not every one of the isolated callosal agenesis cases will do good. There is a substantial proportion of cases with various degrees of impairment, language function, and cognitive function, and in motor function. Also, studies vary according to what percentage you have a bad outcome and a good outcome. The isolated callosal agenesis case, also because different studies use different criteria on what subtle abnormalities might be still included in the isolated cohort. Contrast to the associated cohort. So what we do know is that certain ACC syndromes have a genetic background and have characteristic appearance, for example, Aicardi syndrome, and here prognosis can be estimated pretty well. What we do not know is why is the prognosis good in most isolated cases, but definitely not in all isolated cases. And to tackle this problem, we in Vienna developed an anatomical fetal MR scoring system in a cohort of fetuses with isolated corpus callosal agenesis and correlated that score with the neuropsychological outcome as assessed by a neuropsychologist postnatally later in life. And the study, if you want to see it, is this here published by a colleague of mine. So that's the fetal MRI score. It scores 7 features in the fetal brain, which score subtle abnormalities in isolated callosal agenesis brain, which would not be in itself viewed as an associated malformation, but still just subtle variations from the norm. You rate that on a rating scale of 0 to 2, sum it up, and the maximum score would be 11. Correlated and then correlated our score with neuropsychological testing for cognitive function, motor function, and language function. And this is our scoring system. It has, as you see here, 7 features, and we will now go through all of them. So I will show you how to score those. So let's start with gyration. We all know that gyration or sulcation of the brain follows precise temporal patterns. So in different time points during gestation, different sulci should be visible. So if you want to judge if gyration of your fetus that you're doing a diagnosis now is age appropriate or not, you can orient yourself according to temporal landmarks, which have been published, or one very useful tool that has been published in the last years are standardized fetal brain atlases. My favorite is the Golipur Atlas. This is not from our working group, but from the Harvard working group. You can download it on this homepage that you see here. And it's a four-dimensional MRI atlas of the human fetal brain between 21 and 38 gestational weeks. That shows you the average fetal brain for gestational week, its location, and it's very helpful in clinical practice. So it looks like this on the axial images, some coronal images. So if you now have, for example, this 30 gestational week old fetal brain with an isolated callosal agenesis, and we want to see is the duration age appropriate or is it delayed, we can load up a standardized template from the Golipur Atlas and compare which is next to each other. And if we do that with this case, then we see that this fetal ACC has an age appropriate duration and not. If duration is normal, we score it as 0. If it is mild delayed up to 2 weeks, we would score it as 1. And if it is severely delayed more than 2 weeks, we would score it as. Keep in mind that sulcation somewhat is correlated to the degree of ventriculomegaly. For example, here you see in the colpocephalic brain, the calcarine and parietal occipital fissures are always a bit more shallow than in a normal brain due to the ventriculomegaly. Next feature is opercularization. Opercularization is the folding of the frontal, parietal, and temporal opercula around the insula. And it also, like duration, follows a temporal pattern. This is how the normal brain looks like at 20 gestational weeks, where you see here an angular shape of the insula and the opercula. And if you compare this to this ACC brain here, then you notice that here the angle of the frontal operculum to the insula is much more flat than here in the normal brain. And here on the right side, it even is rounded. So this is rather how opercularization would look like in a 20 gestation week old brain, I would say. And if you see delayed opercularization, you score it as 1. Here another example, isolated case of callosal agenesis. If you compare it to the normal control, you see here that the lateral Sylvian fissure is much wider than in the normal brain. Also in the axial images, you see here opercularization is much more delayed in our ACC case than here in this normal case. Also this brain you would score as 1. Next would be temporal lobe asymmetry. The interesting thing about the fetal brain is that it is not a symmetric organ, but an asymmetric organ. This is most pronounced in the shape of the temporal lobe, the depth of the superior temporal sulcus. Superior temporal sulcus appears earlier on the right side and only 1 to 2 weeks later on the left side. And if you look here at the shape of the temporal lobe in the coronal plane, you also notice that it is asymmetric. So on the right, there's a rather angular shape, whereas on the left, there's a more rounded shape. So this is a normal appearance. Fetal brain should be that it is asymmetric in this regard. You see a movie of development of the superior temporal sulcus over the course of gestation. See it appears earlier on the right side, later on the left side. And also it is more deeper on the right side than on the left side. This is how it should look like, normal asymmetry with a deeper superior temporal sulcus on the right and on the left. If you now look at this callosal agenesis brain here, you see that don't see an asymmetry here. It's those are symmetric temporal lobes, and this is an abnormal asymmetry pattern. This here is a case of inverted asymmetry. Here you see the superior temporal sulcus early on the left than on the right. So if you either see a symmetrical temporal lobe or an inverted asymmetry, you score that as 1. This is another study from our research group that showed that the temporal lobes, both in partial callosal agenesis as well as in complete callosal agenesis, are less asymmetric than in a normal brain. So what's the possible consequence of that? This is one example of a isolated corpus callosum agenesis, but with atypical asymmetry pattern of the temporal lobe, as you can see here, compare it to the normal controls here. And this fetus after birth showed a delay in development as well as autism-like features. Temporal lobe is important in language functions, in higher cognitive functions, in memory functions. And we see this atypical asymmetry not only in callosal agenesis, but also in other brain models. Next, hippocampi. Here in the middle, the normal appearance of the hippocampus on coronal images in the 27th week. See it is rotated into the temporal horns of the ventricle. If you compare it here to this case of a callosal agenesis, you see a malrotation. So it's much more vertical than in a normal case. If the malrotation is mild or moderate or unilateral, you would score it as 1. And if it is very pronounced, like in this case, where hippocampi are vertical and reduced in size, we would score it as 2. This is a study that another co-worker of one did in collaboration with the Brain Institute in Zagreb. She did a volumetry of the hippocampi in the postmortem brain on postmortem MRI, on super resolution MRI, and she found that both in the isolated and the associated corpus callosum cases, there is a reduced volume of the hippocampus. It's much more pronounced the associated group, but also here in the isolated corpus callosum fetuses, you see, in comparison to the normal controls, a reduction of volume, which gets more pronounced, increasing gestational age. Next point, lamination. Lamination is very important. It's very well, it is one of the highlights that you can do with fetal MRI. We all know in the second trimester that telencephalon has several layers that can be visualized both on MRI and on histology. So the cortical plate, subplate, the intermediate zone, and the ventricular zone. In the 5th month, about gestational week 20, this can be very well seen on T2 weighted images. We see here a dark cortical plate, a bright subplate, the intermediate zone, which has an immediate signal intensity, and again in dark, the ventricular zone where the germinal matrix is, and those signal intensities are mainly related to differences in cell density and extracellular matrix and water content. In the 6th month, as you can see here, those layers are not that well differentiated anymore, especially the subplate and the zone are not be discriminated that well anymore on a T2 weighted image. But in those cases, the FLAIR images are a very important new addition to our fetal MRI protocols. We now have epi-FLAIR sequences and FLAIR sequences in, and here especially subplate and the intermediate zone can very well be differentiated because the subplate is very high in water. Therefore, it has a partial suppression of signal on the FLAIR sequence. In addition to FLAIR sequence, you can also look at the lamination on the weighted images, which also works quite well. So this slide you've seen yesterday. This is fetus with a callosal agenesis with focal cortical malformation here, and then abnormal lamination here in the left frontal lobe. Now, no one would diagnose a fetus like that as an isolated corpus callosum agenesis. It's clearly an associated corpus callosum agenesis, but there are also more subtle abnormalities in lamination that can be found with MRI and which were typically included in the isolated callosal agenesis cohort. For example, very important part of lamination is the germinal matrix, the ventricular zone, and the ganglionic eminence. Here, the proliferation of interneurons, especially in the ganglionic eminence, the proliferation of interneurons takes place that then tangentially migrate into the cortex. We look here at this fetus with agenesis of the corpus callosum, and you look here at the ganglionic eminence, you notice that it is much more prominent and thicker than in a normal fetus, or here in the standardized brain atlas. So every time you see very prominent ganglionic eminence, you should classify it as an abnormal lamination. Because here again, interneurons are created. Normal size may be related to an abnormality of migration to the cortex, which probably profound neurological sequelae. So a case like that would score with 2 points. Other area which you should pay close attention to are the crossroads regions of the brain. It's those regions here in the fetal white matter. It's where the retrolenticular part of the internal capsule exits between the caudate nucleus and the putamen. And it contains crossroads of different fiber types. There are corticospinal fibers, there are thalamocortical fibers, external capsule fibers, and association fibers, all in very close proximity. And might guess that if there are that many different fiber systems, very close proximity in this area, that abnormality here can profound changes in function of fiber networks. You judged it not on tractography, but you look at the signal intensity. If you look here in this ACC case on the left, see here the triangle region, a very prominent hyperintense signal on the T2 weighted image, and a pronounced suppression on the FLAIR images. Now, also in the normal brain, you can see the triangles in second trimester to some degree, as you see here in this brain. Also on 3 Tesla, they are a bit more prominent than on 1.5 Tesla. But this signal intensity here is much too high. It shouldn't be that high. And also the strong suppression on the FLAIR points. This is an abnormal signal in this region. Also, this should be classified as an abnormality of lamination given points. We yet don't really know yet what the neuropathological basis for this abnormal signal abnormality is, but we also see it in various brain malformations. Here, the same fetus 4 weeks later. Here again, hyperintense crossroads on it too, with the suppression. Yeah. So next feature would be the basal ganglia. Here, basically, you should look at the size of the basal ganglia, are they asymmetric, and the signal intensity. And if you notice there anything changing from the norm, you should give it 1 point. Also here, the comparison to the normative standardized brain atlases are very helpful. And then finally, ventricular size. Colpocephaly itself is not a pathology, it's or an additional associated pathology. It's part of the syndrome. It's the typical shape of the lateral ventricles with narrow verticalized frontal horns and enlarged occipital horns. But what you should score is the degree of ventriculomegaly. We scored a normal atrium size as 1. We included both mild and moderate ventriculomegaly as 1 point, and the severe ventriculomegaly is. And then you add everything up and get to a score. And these are the results. We had in our cohort 21 cases of isolated corpus callosum agenesis that were followed up with neuropsychological testing. And we found a significant negative correlation of the MRI score for cognition, motor skills, and language. And the cutoff is about 3. So if you score 0 to 3 points, your fetus has a very high chance of having a good neurological outcome. If your fetus scores 4 points or higher, you have an increased risk for poor neurological outcome. And the more you score, the higher the risk group. We also looked at that in other in fetuses with associated malformations, and found that also the score here in these extended to this cohort was able to predict the functional outcome with an accuracy of 95%. So the next time you see an apparently isolated agenesis of the corpus callosum, look at those subtle abnormalities, which might have a pronounced impact on the future neurological function of the patient. Thank you very much for your attention.
Thank you, sir.
Let me understand, because you say we have 74 cases that were considered isolated, and after that you say if they are not isolated, the prognosis is bad. Knowing that the prognosis is bad because you know that patients that have have associated anomalies have a bad prognosis. What you did is to look more in deep and to try to recognize that were considered false negative for associated anomalies. You find the associated anomaly and you say now the prognosis will be bad. It's something that is clear that if you miss the associated malformation, you will say this child will have a better prognosis.
That's exactly the point. You have to look for very subtle abnormalities also in an apparently isolated case, because those can be the tip of your iceberg, can point to a more general abnormality of the brain. So you can't just exclude, cannot just look at major malformations of cortical development, posterior fossa malformations also. You have to look at those tiny subtle differences, and if you use that score as a scaffold, as a guide to do a standardized report on those cases, you can increase your ability to separate the high risk patients with a poor outcome from the ones that have a better.
So I think that here perhaps is the best contribution we have, or one of the best contributions we had from fetal MRI, because fetal MRI has teach us obstetricians what to look for, and after they realize that this is what they're showing, you know what to look for, because we were not aware what to look for, and I think that this is perhaps the best contribution of MRI.
Thank you for your excellent presentation. Do you have any correlation with genetics data for your poor outcome or your good outcome?
We also did. We also looked up the genetic from that, but I don't have the data. It's included in the paper.
It's really interesting to see when it's poor or when it's bad or poor.
But what I forgot to mention is that this score you can also use for neurosonography. This is why we also didn't include tractography in this score, because we wanted to make it both applicable to fetal MRI and to neurosonography.
Yes.
Okay. I have a question and a comment. First, thank you for your amazing lecture and as Gustavo said, amazing new data regarding to the new approach to the isolated complete genesis of the corpus callosum. I have two comments and one question. From the anatomic point of view, maybe we can divide the complete genesis of the corpus callosum between the real abnormalities in the cortical, in the anatomical cortical development, okay, and maybe we can consider the normal findings on the function of the fetal brain, okay. It's one I mean, correct approach to these new findings in your data. And the second point is because in the complete genesis of the corpus callosum, we find a new abnormal development of the cortex, of the brain cortex. For example, I spoke with Daniela regarding to the cingulate sulcus. If you think about it, in the complete genesis of the corpus callosum, in all the cases, you do not find the normal anatomy of the cingulate sulcus and or the cingulate sulci, and the fact that maybe they kind of new anatomy can be produced. What do you think about? And thank you for your amazing lecture.
Yeah, thank you. Actually, in that study that quantified the asymmetry in the brain and the brains of callosal agenesis cases and compared it to normal cases, I didn't talk about it, but they also found reduced asymmetry of cingulate gyrus. So there's definitely, I think, a lot more subtle findings that we have to look. Callosal agenesis brains, definitely much more to discover and very carefully looked at when
no, I wanted just something that similar to he was just asking. I mean, this is a very key topic, a very important talk about the isolated genesis. But my concern is that, especially about comparing the shape of the gyri and the location between the template, normal template, and the isolated CT, because it's like comparing peaches with apples. In fact, if you want to put within a statistical template of the fetal brain, the brain of a isolated ACC, they don't fit. So it's very hard, very, very hard to compare gyration index and symmetry. Well, that's really my concern.
It's very hard for a machine to do that. You still need the clinician that looks at the images in its head, also with experience, to judge if it's age-appropriate gyration.
And also inter-observer variability is a big issue here when they judge about gyration to different observers.
And the last one.
Some of the, as an extension to his question, some of the subtle gyration abnormalities are going to be very subjective. So it's going to alter the score in what somebody perceives. So would there be a role for artificial intelligence for you to outline these subtle things and give it as a AI rather than have individuals across the world looking at subtle asymmetry in the gyrations? Because the validation across the world for such a paper would be very difficult.
In this study, actually, the rating was done by an experienced fetal MRI specialist and another colleague with only a minimal training. And we found between those people rather good in reliability. So I think if you know how to score it, it's pretty straightforward. Of course, like everything, you can have some variation, but we found that we can apply this for treating. And concerning AI, well, at some point, AI definitely will replace us, but no one knows when that will. Let's hope not to.
Thank you. Thank you very much. Now, because we are running a little short of time, may I invite Dr. Ramamurthy? Please. Daniela.
That I can give you this medal. And
this is this way.
today, but for you develop your development
Modality.
of fetal tractography that because almost all of our tractography examples are done by Christian, and he really has brought this method to a flourishing method that can now be applied all over the world. So thank you for that.
Romina Romaniello from Italy. She's assistant at Department of Child Neurology and Psychiatry, Scientific Institute, where she does research activity in the field of rare neurological diseases and brain malformations of developmental age. She has more than 73 articles published in her name. She's a professor at the University of Pavia, School of Specialization in Child Neuroscience.
Can I request you to wait for one? Professor Yamada, this is remaining for you. You were not there in the morning. Thank you.
To this wonderful Congress. I'm very honored to be here. So, living with agenesis of corpus callosum. In 2006, 63 young patients with agenesis of corpus callosum were studied by clinical team of Professor Renato Borgatti and in Neuroradiology Research Lab of Filippo Arrigoni in Eugenia Medea Scientific Institute in Bosisio Parini, Italy. And it was a preliminary study In this study, an extreme clinically heterogeneity of this patient was observed, and with difficulties to predict the clinical outcome was evident. So this study continued, and to the previous 63 ACC described patients underwent follow-up, 99 new cases were enrolled. So these patients and reached in 162 ACC patients, complete and partial ACC, were studied in the study in 2017. They were divided in 4 groups: syndromic and non-syndromic patients on the basis of the presence or absence of extrabrain malformations, and plus an isolated ACC patients on the basis of presence or absence of associated brain malformations. This study led to more incisive results, and were concluded that patients with isolated complete ACC had the better outcome. In this flowchart, you can see the population of these 162 ACC subjects. There were 56% of males, 69% were syndromic. Complete ACC was in 52 patients. In isolated ACC group, 70% have complete ACC. In plus ACC group, 61% have partial ACC. No significant difference between partial and complete ACC is observed in syndromic or non-syndromic patients. The most relevant outcome indicator is the presence or absence of brain-associated malformation. So, extrabrain anomalies that were observed in syndromic ACC population is indicated in this table. So, ocular region in 88% was the most frequent, then cranial anomalies in 64%, external ear malformation in 50%, skeletal anomalies in 42%, oral region anomalies in 40%, heart anomaly in 44%, genitalia anomaly in 17%, urinary apparatus in 8%, and skin anomalies in 3%. Clinically defined syndromic diagnoses were found in 37 cases, 43% of patients. The diagnosis was confirmed by genetic tests when possible. Karyotype detected pathogenic chromosomal rearrangement in 17 cases, 10%. CGH array detected pathogenic CMV in 11 cases, 10% of patients. Aicardi syndrome represents the most frequent condition. 9 patients presented this syndrome. Plus SCC patient, subgroup complete ACC, prevalence of supratentorial malformation was observed in 65%, in particular malformation of cortical development, while in partial ACC patients, a prevalence of in-brain cerebellum and brainstem malformation was observed in 50-60% of patients. So this is the specific syndrome in this table. And Aicardi syndrome is the most frequent represented in 9 cases. Results of this study was that developmental delay and intellectual disability are present in 90% of the patients. All syndromic patients present intellectual disability. 12 subjects of non-syndromic isolated ACC have IQ ranging from normal in 8 cases to borderline in 4 cases. Among these 10, 83% have complete ACC. Learning disabilities are present in 8 subjects. The cognitive profile is disharmonic in 9 of the subjects, with significant difference between performance and verbal scores. Among these, all the 4 subjects with borderline IQ due to a language disorder. In 9 of these 12 patients, present memory deficits, verbal and visuospatial memory. Complex non-syndromic isolated ACC subjects present the best neuropsychological profile. The worst outcome indicator seems to be the presence of associated brain malformation, and intellectual disability is also present in non-syndromic subjects, 64%, 93% ICC plus versus 43% isolated ACC. This is the profile of the 12 subjects with the neuropsychological profile of the 12 subjects with IQ ranging from borderline to normal. You can see that only 2 subjects present partial ACC, and you can see the distribution of attention, difficulties, visual spatial memory, verbal memory, visual perceptual skills, motor and visual spatial and graphic skills that range from normal to border or plus impairment of different range, language and academic performances. But what literature tell us about several studies focused on studying the neuropsychological profile in anagenesis of corpus callosum subjects. This is a systematic review performed by Vanessa Siffredi in 2013. This is a meta-analysis study of 47 publications. This is the distribution of the IQ ranging from extremely low to very superior, and also divided from verbal IQ and performance IQ. And we can see that a rate of impairment is present. For example, language impairment in expressive and receptive is 75%, in pragmatic skills 10%, psychomotor speeding 70%, cognitive information processing are impaired in 75%, and also attention is involved in 7% of subjects. Also academic skills are impaired, and we can see that age range of this study is from 8 to 45 is a long study, a long follow-up. A neuropsychological profile of agenesis of a corpus callosum subject was a study always from Siffredi in the study of 2018. The study 28 subjects, school-age children from 8 to 17 years with ACC. And the author concluded that the half of subjects with the general experience, general intellectual, academic, and executive and social and behavioral difficulties, and 20% were functioning at a level comparable to typical developing children. Social risk was important for understanding variability in neuropsychological outcomes. And you can see that developmental delay is present in 46.4%, also spatial development, and also in interventional therapies as a speech or occupational or psychological therapies was performed in about 60% of subjects. So you can see also the percentage of impairment of this subject. So in the recent year, diffusion and progress of prenatal diagnostic techniques increased diagnosis of fetal malformation, but the presence of open question on the outcome of patients with ACC led to the question if prenatal diagnosis of ACC subjects, what is the outcome of this subject detected in fetal age. So we can observe some literature data. This is a study of Sotiriadis in 2012. This is an analysis of 16 studies with studies by fetal ultrasound and fetal MRI. 71.2% had normal outcome, 40.6% borderline outcome, and 50.2% had several intellectual disability. Fetal MRI detected 22.5% of non-isolated subjects, and this is isolated subject. 75.4% had normal outcome, and 11.6% had several intellectual disabilities. This is the table that documented all this. But these 16 studies, only 6 evaluated cognitive and neuropsychological development and function with appropriate tests and not just anamnestic data. And follow-up age is generally very low, on average 4 years, with difficult to detect language, learning, or behavioral problems, which become more evident later. For example, in the survey by Yi et al., epilepsy in a case classified as severe appears at 10 years old. So in this study of Moutard in 2003, is evident the importance of this outcome study of long follow-up and appropriate age-related tests, cognitive tests, because cognitive and behavioral difficulties appear with the age. 12% at 2 years, 55% at 4 years, 71% at 6 years. And the same patients were studied after some years in 2000, in 20,000, and isolated corpus callosum agenesis, a 10-year follow-up after prenatal diagnosis. In this subject, we can see that only 11 children participate to this follow-up, and 8 were in the normal range. Also, half of these children experienced some difficulties in scholastic achievement. So outcome is mostly favorable because intelligence is within the normal range for nearly 3 out of 4 of the children. However, they frequently have mild learning difficulties. And this is the table that explains of this. You can see the IQ, the verbal and performance IQ, school adjustment in 5 subjects, and rehabilitation in 6 subjects. And this study also this study confirmed this that intellectual abilities can be normal as IQ above 85% in approximately 2/3 borderline in just over a quarter of patients, but a low risk of severe cognitive impairment exists, and this information should be shared with complex during prenatal counseling. These are the data. And also this study of Le Folio Le Dussal confirmed this data. So we explain you our experience in 2021 in collaboration with the Pediatric and Neuroradiology Unit of Buzzi Hospital, Children's Hospital of Milan, and Professor Righini. Professor Righini studied since 2004 more than 2,000 fetal MRI performed, and more than 93 isolated complete ITT where the ACC were subjects were detected. This long-term retrospective follow-up study aims to address the knowledge gap between prenatal diagnosis of complete isolated agenesis of corpus callosum subject at fetal MRI and postnatal neurodevelopmental outcome, and to explore the role of a prenatal MRI-based diagnosis of isolated complete ACC. A detailed postnatal clinical, neuropsychological, and neuroradiological and genetic data were provided. The study had 5 phases: enrollment, a telephonic interview, a clinical evaluation protocol, a neuroradiological evaluation, and genetic study. So the enrollment, the starting database of 93 isolated complete ACC subject, 16 therapeutic miscarriage, and 1 intrauterine fetal death. So only 76 subjects were considered, and 26 were lost, 22 lost during follow-up, and 4 refused to be contacted in future studies. So only 50 subjects were really enrolled in the study. Gender was 26 male and 24 females, age ranging from 2.5 to 15 years. So enrollment at telephonic interview was administered a clinical questionnaire on pregnancy, delivery, and development by a child psychologist to parents. And then a clinical evaluation protocol was performed, pediatric, dysmorphological, and neuropsychiatric evaluation, neuropsychological evaluation protocol in accordance with age, with cognitive, motor skill, and visual motor integration, visual perceptive, visual spatial, language and pragmatic of communication, attention, memory, executive function, and behavior. This is the CC telephonic interview that was administered with data on pregnancy, on delivery, on developmental milestones, school difficulties, behavioral difficulties, clinical medical history, on the neuroradiological study, fetal study, and postnatal study, clinical, if it was performed, clinical assessment, and genetic analysis. Neuropsychological evaluation protocol was administered in age-related with cognitive assessment, so Bayley scales of vascular preschool or vascular intelligence scales for children, motor skills and visual motor integration, language and pragmatic of communication, age related, attention, visual attention or auditory attention, memory, short-term memory and long-term memory, executive function, and behavioral assessment by Child Behavior Checklist, CBCL. Neuroradiological evaluation protocol consists of fetal MRI performed from 24 to 34 weeks of gestational age and postnatal MRI by 3 Tesla MR scanner with an acquisition of standard morphological examination and tractography study, different tensor imaging DTI. A genetic study was also performed, molecular karyotype, CGH array, next generation sequencing by panel of ACC genes and negative or familiar cases by co-clinical exome, oval exome. This is the gene list of the 153 NGS-ACC panel that was performed. And the classification, the neuroradiological classification was described in a study of Cesaretti and Righini in the study of 2016 that divided the subject in 4 groups. Group 1, absence of commissures. Group 2, only anterior commissures. Group 3, anterior and hippocampal commissure, and group 4 with hybrid corpus callosum consisted of anterior commissure plus residual vestigial hippocampal commissure and the rudiment of the corpus callosum. So fetal MRI classification in the 50 isolated ACC subject detected 4% in group 1, 42% in group 2, 38% in group 3, and 26% in group 4. This is an example of group 1, absence of commissure, 4% to subject. Group 2, only anterior commissure, 42%, 16 subject. Group 3, anterior commissure and hippocampal commissure in 38%, 19 subjects, and group 4 with the hybridus corpus callosum, 26% in 13 subjects. The same classification was applied to the postnatal MRI. The postnatal MRI were classified in the same way, but only 43 subjects was performed, only 2 or 43 subjects was performed postnatal MRI. So only in 66 subjects was performed as postnatal MRI. And the distribution is 3% group 1, 43% in group 2, 40% in group 3, and 24% in group 4. So this is group 1 of postnatal MRI, an example, 3%, 1 subject. Group 2, only anterior commissure in 43% in 14 subjects. In green arrows are the anterior commissure, you can see. In group 4, anterior commissure and hippocampal commissure in 40% in only in 10 subjects. Green, you can see anterior commissure, and red hippocampal commissure. And group 4 with the hybridus corpus callosum, 24%, only 8 subjects are present. And in green, anterior commissure, in blue, the hybrid corpus callosum. Then a comparison between fetal and postnatal MRI was performed, and you can see that a prenatal postnatal concordance was obtained in 26 of the 33 subjects, so in 69% of subjects. In group 1, in 60%, in group 2, 78.6%, in group 3, 72.7%, and group 4, 7%. About the comparison between fetal and postnatal MRI, 8 subjects, so 24%, resulted not isolated at postnatal MRI. So presented additional finding. You can see in one case the presence of UBOs in subject with neurofibromatosis type 1. In one, we have not imaged two small periventricular nodules and mild chiari-1 malformation. In one subject, an abnormality of cerebellar foliation. In one subject, a brachycephaly. In 3 subjects, the presence of anterior interhemispheric cyst. And in one subject, a small temporal left arachnoid was detected. The developmental milestone of this subject was, this is the distribution. You can see normal, in the motor area, normal developmental was in 62% of subjects, and borderline 19%, and pathologically 19%. In language area, normal development in 45%, borderline development in 22%, and pathological development in 33% of subjects. In cognitive area, you can see that 63% of subjects have normal developmental, developmental performance, borderline 17%, and pathological in 20%. Neuropsychological profile, neuropsychological, linguistic, behavior, and academic skills profile of the 38 subjects over the age of 6 years is described in this table. You can see that intellectual function was normal in 50% of subjects, borderline in 29%, and pathological in 21%. The motor abilities were normal in 42%, borderline in 8%, and pathological in 50%. Visual motor integration in 58%, and pathological in the remaining 42%. Memory was normal, memory function were normal in 42%, and pathological in the remaining 58%. Executive function were normal in 63% of subjects, and pathological in 18.5%, the same borderline in 18.5%. Language was normal in 39% of subjects, borderline in 49% of subjects, and pathological in 22%. Behavior was normal in 79% of subjects, and pathological in 21%. Subjects with academic abilities difficulties were 24%, and normal skills were in 47%, and borderline skills were in 29% of subjects. Rehabilitation, you can see that subject 40% of subjects performed motor therapy, speech therapy in 45% of subjects, special education in 55% of subjects, occupational therapy in 43%, and teacher supporting in 53% of subjects. And there is a correlation between developmental outcome and fetal MRI and postnatal MRI classification, and no significant data were were observed in between this correlation. The only significant correlation is between the presence of cognitive impairment and presence of additional postnatal MRI finding. So when you have a presence of additional MRI finding to postnatal MRI, you can see the presence of intellectual impairment. This is the only significant results, a correlation of this study. These are the clinical features of the cohort of the 50 complete AC subjects. So you can see that there were 52% of female subjects, normal pregnancy delivery in 82%, microcephaly at birth was in 8%, epilepsy in 2% of subjects, extra-brain associated finding in 10%, a diagnosis of genetic condition in 16% of subjects. Genetic findings was performed a CGH array in 26 subjects, was normal in 16, pathological in 4, and a variant of unknown significance in six subjects. De novo deletion in 13q32 de novo in one case, a de novo deletion in 17q 11.2, including NF1 gene in neurofibromatosis disease in one case, as a partial trisomy of 8 chromosome mosaicism in 2 cases. A panel of ACC genes was performed in 22 cases and with normal results in 5 patients, variant of unknown significance in 15 patients, and pathological in 2 patients. A de novo homozygous variant C124557 gene and de novo heterozygous variant in SEB2 gene, Mowat-Wilson syndrome. Results summarized of this study is that 38 school-age children older than 6 years of 50 patient age from 2.5 to 15 years show normal intellectual function in 50%, intellectual disability in 21%, and borderline intelligent quotient in 29%. Deficits in motor functions in 58%, executive function in 47%, language in 61%, memory abilities in 60%, academic performance in 53%, and behavior deficits in 21% of patients. Almost half of the participants underwent a rehabilitation program. Additional findings, 24% were detected at postnatal brain MRI. A significant association between additional findings at postnatal imaging and a normal developmental outcome was observed. The proposal classification system of fetal MRI showed a good concordance between pre and postal exams, but does not allow to identify any outcome index. In the absence of early prognosis indicator, the fetal diagnosis of isolated ACC should lead to a careful follow-up during the develop an early and intensive rehabilitation program. Conclusion remarks. Children with prenatal diagnosis of isolated complete ACC may present with several degrees of neurological and neuropsychological impairment, which become more evident only in their second decade of life, such as neurologic and neuropsychological impairments, such as deficits in executive and linguistic functions and learning disabilities. Behavioral difficulties, including deficits in social communication or interaction, or in emotional or social control, inhibition, and hyperactivity were also observed. Postnatal MRI and detailed genetic analysis may add crucial information to prenatal data and influence final judgment on the outcome and orient clinical management and counseling. Also, the prognosis in isolated ACC patients is generally favorable, and it is consistent with adequate quality of life. Pathologic findings presenting less than 25% of subjects. A deep neuropsychological evaluation allows to identify not straight pathological, but more often atypical development. A real pathological role is played by the presence of associated brain malformation not detected during fetal MRI. This study is posterior to our study, and also in this study in 2022, vulnerabilities in executive function and social cognition were found with particular difficulties on complex and novel tasks, so confirm our results. Future direction, perhaps studies of intra and interhemispheric connectivity will be necessary to support the hypothesis that the presence of intellectual disability in ACC is probably due to a disruption during brain development of the normal neural connections involved in cognitive function. So this kind of study is necessary to be performed. I thanks to Renato Borgatti, Filippo Arrigoni, Andrea Righini, and all my collaborators. Thanks for the attention.
Thank you so much, madam. That was really informative.
Romina, nice to have you with us, and congratulations for the fantastic lecture. You bring data that most of us are not aware or are partially aware, and I think the important thing is that when everything happens to be normal, after delivery, things may change. This is one important conclusion. If you have 10 to 15% have something else. The question is, did you perform the exome or the genetic evaluation before delivery to give counseling, or that was diagnosed only after? You didn't know that you have a Mowat Wilson because the prognosis, for sure is bad. So I think that the evaluation should be performed if you have the possibility to terminate before delivery. So we'll exclude some of these cases. And years ago, I think it was 2003 or 4, I was in Vienna, and Professor Ribot gave a lecture, and Professor Ribot is perhaps the father of pediatric neurology in congenital disease. He's the mentor of Barkovich, and he gave his lecture on corpus callosum agenesis, and he tell us, I have never seen a completely normal children after the age of 6, and he was working in the field for 40 years. And later on there is the publication from California from the group of Sharon Paul that they study adults with known agenesis of the corpus callosum, and it turns out that most of them, they have very social problems. As you know, if you're completely mental retardated, it's okay because you don't know that you're mental retardated. But if you have mild mental retardation, you will suffer from your whole life. And these persons at the age of 30, 40, 50, they stay at home, they didn't marry, they work in very, very simple tasks. So, and when we used to tell, or people used to tell the patients, if there is apparently isolated, the chances that your child will be normal are 70% or 80%. But all these considerations that I am speaking about and Romina speak about should be taken in consideration when you tell the patient what to expect. And eventually the parents are the ones that will decide what to do if you can terminate. But thank you again, fantastic conference. You put it very clear, and I think that everyone understands that we are not still there.
Thank you very much.
And this is the same pattern that we find in our study when we look at the pathologies of fetus that were terminated because of complete agenesis of the corpus callosum. Our pathologists call us, say, they're completely wrong. There is no agenesis of the corpus callosum. Some remainings are always there. And what happens is that when you perform an examination, you see the corpus callosum is very small. I show you the cases in X-linked hydrocephaly. But let's say that you fail to make the diagnosis, and at the age of 3 or 4, the children is not doing well. You perform an MRI, and many times the MRI says there is complete agenesis of corpus callosum, almost complete, because this small corpus callosum failed to continue growing. So remember that, and think this is a very important data.
Very important, because if you think that, let's make an example, when you're a fetus, you have like 10 axon remnant of corpus callosum, and then when you scan and it is like 6 years old and they are myelinated, they are 3 times, 4 times thicker, you may end up to see them, those 6 axons.
So thank you very much.
Professor Andrea Regini on midline defects, when and why I prefer MRI over UST.
Good afternoon. Thanks a lot for the very exciting morning. What we saw in the morning was really amazing, especially the ultrasound data. I really think MRI should move forward with some technological advances that has not been done the last 10 years. I still think that our pixels are about 1 millimeter in plane for normal imaging, and for DTI even millimeters. So we are really way back with respect to ultrasound in terms of spatial resolution. So I am going to give you quick some snapshots about what has been already extensively assessed in the morning about midlines structural anomalies, and so it's just a sort of summary. And traditionally, what have been done so far, that when you ultrasound, they notice something wrong about midline structure, entities like septum pellucidum, corpus callosum area, or the around the third ventricle hypothalamic area. An MRI is often prescribed, and especially when those anomalies seem to be mild, because we always are afraid or scared that could be the tip of the iceberg. So we do MRI because we want, of course, as I said in the morning, for associated anomalies which can influence the prognosis. So, and also because in midline anomalies can encompass a large variety of entities. And of course, nowadays you don't ask for MRI for cases like this one, like in the range of holoprosencephaly cases, but still in the same range when you have to address like minor case, so-called minor cases like the interhemispheric variant. This case, which actually is nicely depicted by, as Professor Manninger showed some years ago, is nicely depicted also by ultrasound, and other things can be interesting though in MRI, like this early case you see here in the range of holoprosencephaly, when you see that you can depict the mouse. Sorry. Okay. You can depict the germinal matrix, which is a joint, which is fused in the middle. That means in this case this is a variant, so probably in the range of receptor for holoprosencephaly, and that means that tells us that the parenchyma is fused because weeks before the germinal matrix itself, which formed the parenchyma, was fused, and this is a quite, I would say, nice demonstration of that. Of course, this is not a very recent slide, so what you see with MRI about midlines, the level of quality is this, and it's important to understand that we, for example, already at around 10 weeks, the splenium corpus callosum should be over the, should stand above the quadrigeminal plate, for example. But nowadays, using 3T, we get some better images. They are not a game changer, but really can help in some way, everyday job, because as you can see here, sorry, the mouse, but anyhow, and we see some structures like the pituitary stalk, like the hypothalamus walls, like the fornix, stuff like that, can be depicted in better details, not only late in the station, 29 weeks, like around 20 weeks. So for this really makes our job easier. Of course, when we deal with important midline structure like corpus callosum, it's very important to measure, to quantify. You should not be a fanatic of quantitation, of course, you're wise and common sense, but it's also important that you don't have to measure, as was said in the morning, the corpus callosum per se in its length, but its ratio with the brain size, as we saw, I was going to see later, corpus callosum per se does not exist. It's just an imaginary structure we recognize because of all the fibers converge there. This is the expression of the brain, which is around him. So around it. So, and also the ratio per se is very important. Usually should be around above a quarter of the size of the brain, the length of corpus callosum. As Dr. Mina Romagnello in nice talk present some data about our experience on a complete agenesis of corpus callosum. We could say using a sort of homemade theory, but it's based on some literature, of course, data, that you could divide a complete agenesis of corpus callosum in 4 groups. Probably the one which is the largest one is that you get a regular number of neurons in the cortex and the brain, so actually shouldn't be so abnormal, but what is not normal are the structures. They make the bridges, like the diffusion grisum, the glial wedges, the hyperglia between and make possible the axons cross the two hemispheres to form corpus callosum. And then there we have two groups, the group B, group C, where you don't have enough neurons, or if and in the group C, you don't have also some guidance pathway mechanism working, so the corpus cannot form. And probably there are cases like the ones recently demonstrated by the group of Vienna, where what is impaired is the pure mechanism of guidance, like in ARID1 gene. So let's come to the first group very quickly. The probably is the most frequent one. You see that the brain is normal size. What is missing are the structure, the bridging structure. So indusium, glial wedge, glia, and when they are not there, the new axon cannot cross. And probably in this group we can subdivide it. So also in the morning, if there are present other or not other additional forebrain commissure, like the first group where you don't have a commissure at all. At all, in the second you have only the anterior, and the third you have the anterior plus hippocampal commissure. As we know, the hippocampal commissure and the corpus callosum, they form together. One is sort of supporting the others, and they shift backward together, so they're really connected each other. And in fact, in the fourth group, which has been already mentioned in the morning, we have a sort of hybrid structure that says dot. This dot is made of two components, like in this exploded example here. And we see that there is sort of dot in the middle, and we do a postnatal DTI. You have fibers, posted yellow fibers that go where the corpus callosum should go, and the other are very connected some way with the fornix, or the sort of hybrid structure. And this not this accounts about probably about 10 to 20% of the form of a so-called complete agenesis, but in this case, you cannot really say that it's 100% complete. Of course, it's very intuitive that you should not have the corpus callosum when the brain is very small, because there are not enough neurons, like in microcephalus, that you actually, there's no material, there's no axonal material, neuronal material to form it, so it's pretty obvious. And sometimes in the group C, you don't have material, plus you have sparse cells, you have those heterogeneous heterotopia across the brain mantles, and so all the pathways are interrupted, are distorted, are deranged, and so the corpus callosum itself cannot form. But as we said in the morning, of course, even if the so-called isolated agenesis, the prognosis is still an open field for research. When it's very important in a practical way to determine when the corpus itself agenesis is not isolated. Of course, as was said, there can be the presence of some ventricular dilatation and ventricular deformation, and some malrotation of the hippocampus is sort of physiological, paraphysiological, let's say, accessory accessor to the isolated corpus callosum. So to make things a little bit more practical, what is based on also our experience and listen here, when you see that the spectrosound there is no corpus callosum, you try the red flag, and you look, first thing you look for cortical anomalies. And we at beginning, like 10 years ago, more when it was a male, we were less concerned that when it was a female fetus. When it's a female fetus, you have the chance that you have the Aicardi syndrome, which was talked about in the morning, and which has a poor prognosis. And while as a male, you are a little bit reassured, but it's not probably the case. First of all, because we know that in generally speaking, in corpus callosum, agenesis is more frequent in males, generally, as we know from a long time. And secondly, because we found that when you look for a cortical anomaly, especially you find a distinct cohort of cases where you have this cortical anomaly unilaterally, especially in the frontal lobe, sometimes frontal mesial lobe, and which really seems unilateral. And 80% of these cases are males, and only minority of them, they have intermediate cysts. This is a sort of quote new topic. has been recently addressed also by a paper of ultrasonographer colleagues about some medial say imprinting. It's a bit heterogeneous. We can talk a little bit later more in detail, but please, the main message is that when you see a male fetus with a complete genital corpus callosum, please look at the frontal cortex, especially of one hemisphere. This is very, I want to get in trouble. You get in trouble when you talk about this topic, which is the so-called not complete agenesis or abnormal corpus callosum, short, hypoplastic, dysmorphic, peak, whatever. There are about a dozen of terminologies about that. We saw also yesterday. So this is a really intricate jungle. And the only thing I would suggest to myself, my colleagues in general, is not to pull together these cases with the classic complete, so-called classic complete agenesis, because it's already difficult to manage this data in terms of prognosis. And then if we mix together, it's going to be even more a nightmare. So please, we'll try to separate to make course as clear as possible. But what is important, as I said in the beginning about geometry itself, is that corpus callosum is not something that exists per se, but is within the context of the brain. So when we do measure, we have to consider that the shape and the size depends a lot about the shape and the size of the brain. If you have brachycephalic, you have a shape, the size, and the length. If you are dolichocephalic, what is important is the ratio. It's not the solution for all the problems, because probably in the future we're going to have a segmentation due to artificial intelligence and a really reliable DTI, high resolution DTI. But for the time being, what we have to use case by case on the clinical routine, please consider the shape of the brain when you consider the possible normality in size of the corpus callosum. So as you see in these cases, they have different brains that have very similar ratios. So we get to those very wide terminology where we say short. Sometimes you can say short when it's really short, like in this 25 case. We can say that this case is really short. In fact, it's still really short after birth. Sometimes the situation is more uncomfortable because you see this is short, but not too short, moderately short. And in fact, the ratio is borderline 0.24 instead of being 0.27. And still after birth, the corpus callosum is to be thin, and more than short, it stays a little bit thin in this sense. On the other side, there are situations where interpretation of the data is a bit more easier, like because you have a short corpus callosum for sure, but what really helps you is to look around the corpus callosum. Look, in this case, you look at the layering. In order to look at the layering, you must compare with normal template. You should always working with the normal template on our PC and see there is a persistent layering at 26 weeks that should be not so remarkable. And also, as you can see, there is some deficit in opercularization. Technical for people doing MRI technical suggestion, please don't use short TE. Sometimes you don't see layering, or the images look so flat on T2 because the people using short TE below 100 milliseconds, and that's why you need a lot of player sequences to get layering. But when you use especially 1.5 Tesla, you use 180, 150 TE, you see more the brain is rich of water, so the distinction between layers is much easier. It's a technical tip. Sometimes you get milder signs, like in this case, we have a corpus callosum with mildly short, so we don't know what to say. And then for some reason, we notice that there is an anomaly of the internal of the labyrinth. You see the posterior labyrinth is the cystic anomaly on the left side. And so you do 1 + 1 = 2. And so you can the scenario, the picture becomes a little bit more worrisome because you have two elements which makes the situation a little more severe than expected. Or other situation where, as you said before, the situation, the corpus callosum, you just see a mildly short corpus callosum, not much else, and then you deeply scrutinize the rest of the brain. You see there is a borderline ventriculomegaly, and there is hippocampus is not as rotated as it should be. Now you have three elements, and then with these three elements, they can shift a little bit your diagnostic power. So it's very important to do the segmentation, the 3D, whatever, but for the time being, doing a consultation with experts, at least 2 or 3 experts that they look together at the MRIs. Sometimes we do independently in each office, everybody in each office, that we get together in one office and we vote. It's not very much scientific, but it's the way it's working today. And sometimes the dysmorphism of corpus callosum is very neat, is very clear, unequivocal, and you can replicate what is very well known from the literature, that all these partial component of the corpus callosum, they may have an oblique course with can do with DTI after birth, but the group of Vienna has clearly demonstrated also during pregnancy with fetal MRI directly. And of course, you can have other kind of dysmorphism, which is the missing rostrum, which often it goes along with missing corpus, missing septum pellucidum in the so-called anterior area, as we saw in the morning. And so this is a totally kind of different situation than the simple shorter corpus callosum. You have a more complex malformation in this region. Also in the other case, you see on with the lesion of the longer arm of the chromosome 2 or 20, you see that there is a very short corpus callosum 21, it's a bit longer at 27, almost normal length, but bad shape even. But what's important in this case is that you look at other things, not just the corpus callosum. You look at the insula, and you see that the operculum. You see that if you compare with the control, the operculum is not nice. It's not shallow. It's quite shallow, and like triangular, and so it must be something going wrong. Just besides the corpus callosum cells that, as I repeat for the again is not a structure per se, but part of the brain. And sometimes, of course, you guys was nicely shown in the morning, the corpus callosum is abnormal because it's part of a more complex anomaly with lipoma, with abnormal fat tissue, which can be easily seen early pregnancy because it's not bright on T1, and so it's usually a bit darker. Sometimes you don't even see, you just see even thicker dysmorphic corpus callosum. And of course, when you do DTI before birth or after birth, in this case, you don't see the classic red signs, like red stripes indicating connection between components. Let's say fibers are not fibers, are components, are artificial electronic components through the corpus callosum. Very important not consider the DTI see as axons, just an electronic elaboration, of course. Sometimes, as again, another example, you have a dilemma because the corpus callosum is thin, but probably is normal. You don't know, you are not very sure. So what you have to look at, as we said in the example before, look at other things, look at the operculum. As also Professor Guibault showed yesterday, the operculum is very important, especially if you compare with how the operculum should be in age-matched control. look at the hippocampus rotation, and then this which anomaly was confirmed in this case postnatally. So you have in this case 3 elements. You have corpus callosum thinner, you have the operculum, which is a bit shallow, and then you have hippocampal same rotation. So it's something more than a simple possible or suspected short thin corpus callosum. Another dilemma that was addressed in the morning and yesterday is the so-called thick corpus callosum, which is thick. The big issue, no solution. Nobody has the solution this problem because it's not so frequent. Probably we'll see more and more because sonographers with their marvelous latest generation machine can really see something that, I mean, I was really astonished in the morning and I also yesterday by which is the level. I should go upstairs to Mariano Lama lab where your colleague is working more than I do. Learn more. Instead of him coming down, I should go upstairs to his lab. And anyhow, I can say that when you see such thick corpus callosum, which is undoubtedly thick, if you compare these are 2 cases, and you compare with the control, is definitely thicker. It's a bit shorter also, but what's really impressive is because it's really thick. So sometimes it happens that you do, for many reasons, there are terminations. Of course, when we talk about the thicker corpus callosum, we are get rid to clean the scenery from the giant brains and big brains. We are talking about normal sized brains because when we get a big brain, it's obvious the corpus callosum is very, I mean, it's very understandable, conceivable. Very can be thicker. It's like being 2 meters tall with long feet. It's obvious. And but then for some reason there was abortion in these 2 cases, and so it was a moral also commitment to publish this stuff. And we noticed, and Dr. Gianna Izzo, who performed this job, and also our pathologists, what they observed that basically most of the thickness was ascribed to the supporting structure to the corpus callosum formation, the bridge structure, which is as you saw in the bottom, this is subcallosal sling, which is sort of glia, which is producing also guidance molecules all together with the inducing rhizome above. They are really thick. There were probably some also in axons crossing, but most of the thickness was due to these structures. And of course, sometimes you get also a more prominent steer of Lancisi, which is the dorsal fornix. We don't have fetal data about, actually I have one histology case, I haven't yet. But this dorsal fornix is funny because it's something that's been neglected for centuries. It was described by Lancisi, an old anatomist, Italian anatomist. And what happened is that there are 2 papers in the literature, one from our group and one from an American group, discovered that they saw that in mental retardation cases, the steer of Lancisi were more prominent, even preserved, but usually they disappear or they become thin physiologically, and then gave reason to thicker corpus callosum in these postnatal cases. What probably happened, and Dr. Malinger demonstrated and talk about that, is that after birth, some of these supporting structure, which are not neurons, they decrease in size, and so the corpus callosum get normal thickened sometimes. Other times not, but sometimes this may happen. And so shifting to the septum pellucidum, which actually is not so distinct from the corpus callosum. Thing you have the hippocampal commissure, which is supported like the bed over which above which the corpus callosum is forming, going backward, the occipital, and then from the hippocampal commissure and the hippocampal fornix, you have the leaflets of the set of fornix. So it's all together. So it's not surprising that when you get anomalies one structure, you get sometimes very often anomalies on the other one. And so, well, there are trivial cases, so-called trivial cases, like was said in the morning, when the sonographer say, okay, I have a problem with the setum pellucidum, please have a look, and we have a look, and sometimes what we do is just say confirm what is already known by ultrasonography, which is the septum is not there, the corpus callosum is normal. The only thing it can add is that the chiasm is there, the optic nerves are there, and pituitary stalk is there. We are pretty sure about pituitary stalk, but about an optic nerve, I underline here too, when you talk to patients, please say, I can tell you, or to the clinician, the consult on your consult, say, I can tell you that I see the chiasm, I see the optic nerves, but I cannot measure them. I cannot say that they are completely as normal thickness or not, because it's below the standard resolution of our image, which I stress again, I highlight again, it's just 1 millimeter square. That means that in the brain mantle, in the thickness of the brain mantle of 20 weeks, you fit from 9 to 11 pixels. That's nothing. And in the cortical plate, you fit in 1.5 pixel, or sometimes 2. So you understand when they do all the fancy segmentation in the literature, what they do, they split the pixel in 4. It's like splitting a $10 bill in 2 pieces that you don't get $20 bill. You just get 2 pieces. So, but that's good for, that's enough to, that your eye, human eye cannot see this artifact, this sort of cheating, you know? And that's why all these electronic, those engineers are doing with us, doctors, they present us with artificial intelligence, interpolations, and fancy things, and we say, oh, nice, nice, but really don't realize which is the amount of real raw data which is behind that. And sometimes you get really surprised when you get data. Really sorry. But having said that, sometimes it's not, we can see that you have not isolated, because you have tiny anomalies like the small heterotopia. What does it mean? We don't know. We have to mention a very nice paper from the Danish group. They did like 5,000 or 10,000 normal kids for a national project, and they listed, this is in New England Journal 2-3 years ago, all the occasional accidental findings, and small nodule of heterotopia are rare, but not so rare. So I could be also a normal variant. I don't know much about in the context of a genesis of a setum pellucido, but generally speaking, and of course, what has been very easily diagnosed by ultrasound is the distortion of corpus callosum. Sometimes there be some problems with ultrasound, but generally speaking, when you have an hemorrhage, even a small IVH grade 1, you can distortion, you get sticking, you get synetia, is get deviated, but it's not should not a big deal in terms of prognosis. Other times we have the pathology is not there for 2 reasons probably. One, just making very coarse picture. One is because it's the cluster based, other because it's net. In my opinion, and other people's opinion, most of the absence of the corpus callosum of the setum pellucidum, sorry, when you have some cortical anomalies or closed lip schizencephaly is classic etiology. Because what happened then, even if postnatally you see that the schizencephaly is very narrow, the cleft, I'm almost finished, 1 minute please. Probably when the fetus is like 14, 16 weeks, it's much larger, and then it gets thinner. And then probably you have this hydraulic pressure or CSF storming effect is destroying the corpus callosum. And these are the examples. So you see very narrow. We don't have corpus callosum. You don't have, sorry, septum pellucidum here, but still you have a schizo, which is apparently close lip. Just in this case, from 10 to 2, because in the bottom it is a bit larger, and then it gets very, very, very close. It just seems that, you can say that is a soul. The Woods called a few years ago like transmantle heterotopias or transmantle polymicrogyra. So, but actually, this is a simple trivial schizencephaly sequelae. And finally, instead, when you have more less clear cases, you can hypothesize this more on genetic side. Like in this case, we have abnormal shape of the frontal horn, very thin corpus callosum, absent septum pellucidum, and so on. And also in this case here, where you have the rostral missing here and not set, you can hypothesize this more on the genetic side. And finally, as we saw in the beginning, we may say when we talk about the so-called septal dysplasia spectrum, about septum pellucidum, about the importance of optic nerves. When you have a normal optic nerve and the other only one is as absent or thinner, that you can say that is unilateral hypoplasia. But if they are both thin, you cannot say for sure. So one is healthy, the contract is healthy, it's much easier. And finally, really finally, there are many things about midlines. I just want to flash on the pituitary region anomalies because it's a very neglected area. In postnatal, when you look at kids about prenatal, about the endocrine problem, we look at the Dean hypothesis, the new hypothesis. That's not possible in the fetus because, first of all, new hypothesis because it's very, very. The only thing you see is the normal hyperintensity 1 gland, which is both together neuro and adeno. It's physiologically hyperintense. But since the agenesis of the hypophysis cells is exceedingly rare, the things instead is more frequent postnatally, we know is the problem with the stalk. So we have to look at the stalk, pituitary stalk, not the gland itself. And so many years ago, we did this paper and see, and now it is much easier. Basically, in multiplanar imaging, you are able to see with MRI the stalk. So you have to look at the stalk routinely. And if the stalk is not there, just by chance, and this were the classic routine you do in monochorionic twin imaging, as many groups are in the world, and you don't see the stalk in both twins, and then they are born, and it's confirmed that there is a stalk is missing. It's not just an academic observation, because what happened also to myself, that I almost lost a baby. That it can be dangerous because when they are born, this baby, you can get sudden onset of hypoglycemia, very severe, and so the neonatologist must know, if possible, of course, that it's at risk of hypoglycemic encephalopathy newborn. So this is just a flash about a very niche sector where MRI can be helpful, but I'm pretty sure that in humans, even before there are already examples in the literature, I don't know, even ultrasound is going to do that. Thank you very much.